we will move next speaker, Professor Joe. So I will introduce Professor Joe. Yeah, Dr. Joe is a member of Korean Government Measures Committee, participated in on-site investigation of the MERS epidemic, and will report his experiences and also citing the statistics. Professor Joe is a professor of epidemiology at Seoul National University, Graduate School of Public Health. He is also serving as an associate director of a Center for Infectious Disease Control in Seoul Metropolitan Government. His research interests include infectious disease surveillance, epidemiology of cardiovascular disease, and tobacco control policy. Dr. Joe graduated from Seoul National University Medical College and spent several years as a clinician in family medicine. Professor Joe, please go ahead.
Hello? Hello? Hello?
Yes? Good.
I hope you can hear me now. It's my great pleasure for me to participate this very exciting experience, because this is my first time ever to try this. Actually, I bought my web camera for this conference. I've never used
Okay.
it before.
Thank you very much.
This is very exciting. So what I would like to introduce to you is a short overview of what happened in Korea in the recent MERS epidemic, and try to reflect on some of the lessons that we can derive, although it's not, we still need to wait for in-depth analysis. There have been some discussions on what we should have done, how we should have done better, and perhaps with regard to this conference, we really missed a lot of potential or possibilities that could have helped us a lot through IT if we had been prepared better. So I'd like to share some of my reflections. And of course, I don't represent the government at all at this point. This is my personal experience. The stage of MERS epidemic in Korea can be divided into roughly 4 stages. First is the beginning, where a lot of people really regret that something should have been done better at this point, although we don't seem to see anything here. But actually what really happened is at this point. Then because of some delays and missing responses, we started to see the second wave, and then the third wave, much bigger wave that really threatened the whole nation, with resulting humongous economic impact. And then fortunately, after quite a while, the epidemic, the outbreak has been under control, and then finally it has ended after a couple of months. So with very brief epidemiological distribution, there were a little bit more males, similar to Saudi Arabian experience, and somewhat similar distribution around 40 to 60 of age. And mainly the distribution reflects the exposure to the virus rather than susceptibility itself, as far as we know. This is a very early paper that shows the early pattern of the initial stage. There was index case who contracted the disease from Saudi Arabia, but he was asymptomatic while he was passing the immigration, and then he developed symptoms. So here's when May 3rd is when the index case returned from the Middle East, and then developed symptoms from after a week, and then he was diagnosed much later, actually on 20th of May, after he spread to several people within the hospital, the first hospital he was admitted. And these were the initial peak among the hospital inpatients where the index case was hospitalized, and they were already under treatment for something else within the same hospital. And then the next wave, this is secondary cases, and the tertiary cases start to occur. But another very unfortunate event here was that because of after the first case was diagnosed as MERS at this 20th and 21st, the hospital staffs had to, a lot of the staffs had to be isolated, actually quarantined, because they were heavily exposed to the case. So they had to be quarantined, and there was no not sufficient remaining staff in the hospital, so the hospital had to be closed. So this is the date when the hospital closed. So the rest of the patients, inpatients, were had to find another place to continue treatment. So they spread out in different hospitals, and then later they were found to have become ill. So these tertiary cases were those who are not already in the first hospital. They were in somewhere else, and then they again spread to other people where they were under treatment in after the first hospital was closed. So overall, up to the end of the epidemic, this is the whole timeline, and the initial peak in the first hospital and the secondary cases in the first hospital, but with the same fashion, the people who were in other places, other hospitals, spread to many people in various different hospitals. So that was the huge peak that came from as a result of the tertiary cases from the first index cases, secondary cases, and then those people who were who contacted them in somewhere else. So it looks like initial cluster was amplified in the first hospital, and then they spread out to different hospitals across the hospital network. So this is important to it is important to recognize there is an existing hospital network across which people move around when they have to be referred. So throughout that network, the cases spread, and then there were secondary amplification. Actually, they are in terms of cases, they are tertiary or quaternary cases, but in terms of amplification, it's in the next hospitals. And then after that huge peak, then the government and hospitals began to realize how to deal with this epidemic, and then they have done their best, and then finally the clusters became smaller and smaller until it was on the complete stop. So it was a series of spread, amplification, spread, and another amplification until it became under control. So this is another view of the network point of view. So the characteristics, the main characteristics among other things was that it spread, the epidemic spread across hospital networks. That means the response or preparedness for any future possibility should be based on the network perspective, the connections, how the hospitals are connected, and how they are spread between and within hospitals. And a second aspect is that cluster sizes vary a lot by hospitals, from just a single case without any further spread to almost 90 additional patients in one hospital. So what determines this cluster size, and how can we improve our environment or our situation to tackle very soon, immediately, against this kind of epidemic, should come from the analysis of these varying cluster sizes. And roughly, of course, there are some aspect of number of visitors. Large hospitals with larger number of visitors have more possibility to have spread. But more important has been how crowded the hospital was, without much consideration of this possibility of emergent new epidemic. And also it's important how the hospitals dealt with the epidemic initially. Some was very aggressive, active from the first stage. Some others were tardy. They ignored the risk, and they responded late to make things worse. And also very important aspect was that baseline capability for routine hospital infection control, how well they can do at baseline, how much they are trained, how much they know about hospital infection control procedures. And those vulnerabilities seem to have been amplified in some of the hospitals. So briefly, the logic of the measure, or the logic of the changes, were at the initial stage, the quarantine was administered after the patients were diagnosed, and that was late. After even they had been a week or so delay for initial many patients, so they already contacted so many people that escaped the surveillance. But later, the government and the response team strengthened the surveillance and contact tracing system, and then they started to quarantine people at the time of the symptom onset. At least they removed the delay, and then later they managed to, the government response managed to bring the level of quarantine more stricter. So a lot of the contacts were identified before the case, the patient who would spread, even develop symptoms. Actually, without symptoms, within the incubation period, there is not much risk of spread. But as the response brings the measure well above this level, then the epidemic started to go down. So with that experience, there have been evolving support from IT, especially for contact tracing. There were heavy usage of CCTV and EMR, electronic medical record, to identify who contacted the patients, the infected patients within the hospital. But unfortunately, a lot of this tracing was after the fact, after they already made that contact. And also, between hospital tracing was very difficult initially, but finally, Health Insurance Review Agency has a system called DUR, Drug Utilization Review System, mainly to identify prescriptions in different healthcare institutions so that they detect any overdosage or any poor multiple prescriptions that might actually create any drug interaction. So this system was first utilized for contact tracing for infectious disease, and this has been very effective and contributed a lot to improve the contact tracing system. And then for community tracing, mobile phone tracking and credit card usage tracking was heavily utilized, but they needed patient consent. So these has been some evolution, some improvement throughout this epidemic. And then this is the data that the researchers or the contact tracing personnel used heavily. So in each individual, this person with wearing a mask, this was a patient, and this patient lying down on this patient does not use a mask, although this patient is wearing a mask. These differences could be identified, and all these possible contacts were traced so that they can be quarantined or isolated or identified before they develop. So initial delay has made all the big waves, and then there were very painful experiences and regrets over the delays. Especially, there were a very difficulty to assess the validity of patients' self-report on their histories because of their memory problems or their intentional hiding. So some initial loss of these contact histories created a huge issue. So it's a painful experience that we should not really completely rely on the self-report. We have to have a very valid and rapid tool for information collection without relying completely on patients' memories. So in summary, although there have been some development in utilizing this information technology, there are so much more to be done in information connectivity and comprehensiveness, because we could not identify many of the moving lines because of the lack of those information, because not all the locations CCTV were installed. And also personnel and laboratory development and hospital infection control need to be drastically enhanced in many aspects from our experience. And then there was always governance issues. So I think that's it, and thank you for your attention.
Okay, thank you, Professor Cho. Does anybody have a question or opinion on first speaker? Okay, we have an opportunity on next speakers. Okay.